Hi, my name is Safal Guru. Welcome to my presentation of acute life-threatening conditions. So for this presentation, I have chosen case scenario of Mr. Birmingham, who is suffering from acute exacerbation of asthma. So I'm gonna answer 4 questions in this presentation. And my first question goes like this. And my first question is identify and explain the high priority clinical manifestation that have resulted in the escalation to med call using a primary service format. So primary survey format consists of A to E assessment. So the high priority clinical manifestation are, so starting with airway, its condition is patent. Concern while the patient is currently patent, there is potential for rapid deterioration due to severe asthma exacerbations. Moving on to next, I have breathing. The condition is not between the flags, red zone, tachypnea, 38 breaths per minute. So when the breaths per minute is over 30, it's a red zone and medical should be initiated as per Clinical Excellence Commission. Likewise, SpO2, severe hypoxemia, 77% in room air. SpO2 under 90% is a match call for normal person. However, for respiratory disorder like asthma, the healthy range is about 88 to 92%. However, for my patient, it is severely low. Only good medical attention can save his life. So long sounds and decreased sounds in the right lower lobe, bilateral diffuse, high pitch wheezes because of exacerbation of asthma. So concerns, severe hypoxemia and hypercapnia, high lactate and low pH as shown by ABC, indicating respiratory acidosis, which have led to high respiration, wheezing, coughing, and dyspnea. All this could severely deteriorate the condition of the patient or even take his life if not treated well. Moving on to next circulation. Condition is severe, tachycardia, 122 beats per minute. Blood pressure is fine. Skin mucosa, flushed face and neck, dry mucous membranes due to severe hypoxia. Cardiac sound, soft murmur over a mitral area. Concerns. We have a concern here. Elevated pulmonary artery pressure suggesting right heart strain and tachycardia as a compensatory measure for hypoxemia from sympathetic nervous system. So next is disability. He is not alert and orientated. GCS 14, not orientated to time, place, or person. Pupil says they are equal and reactive to light. However, we have altered mental state, possibly due to severe hypoxemia and hypercapnia, as there is not enough oxygen flow in the brain, which is leading him into disoriented. Exposure condition, febrile, his temperature is very high, 39.2 degrees Celsius. Is unable to lie supine, tripoding, needing support to walk. The peripheries is cold, centrally warm, concerns severe infection, sign of systemic inflammatory response. He has fever and altered mental states. So based on the case study, hypoxemia, hypercapnia, systemic inflammatory response, pulmonary hypertension are the highest priority clinical manifestations. So all of these have led to medical for Mr. Birmingham. So that quick medical intervention could be done to address his problems and avoid the further deteriorations. So I have question number 2 is describe the pathophysiological link to identify high priority clinical manifestation and the diseases condition that the patient has. So these are the 4 these are the 4 identified clinical manifestation as per previous questions. So I'm going to describe this, how it is linked to my patient as he's suffering from exacerbation of asthma. So hypoxemia and hypercapnia. So Mr. Birmingham's severe hypoxemia and hypercapnia are largely linked to his acute asthma exacerbation. Asthma is characterized by chronic inflammation of the airways, bronchoconstriction, hyperresponsiveness, and increased mucus production. During an acute exacerbation, these pathophysiological processes intensify, leading to significant narrowing of the airways. This results in decreased airflow, diminished gas exchange, and following hypoxemia, as shown by his low SpO2 of 77% and partial oxygen of 49 mmHg. The body's compensatory mechanism to improve oxygenation, such as increased respiratory rate, tachypnea, initiates. However, they become overwhelmed in severe cases as there is excess use of accessory muscles, contributing to respiratory muscle fatigue and further worsening of hypoxemia. And that was hypoxemia. So hypercapnia. The hypercapnia, he has hyper PaCO2 of 120 mmHg, which is severely high. This is a direct consequence of inadequate ventilation due to severe bronchoconstriction. In asthma exacerbation, the obstruction of airflow prevents adequate expulsion of CO2, leading to its retention in the blood and subsequent respiratory acidosis. This is reflected in the patient's arterial blood gas analysis, showing a pH of 7.16, indicating respiratory acidosis. The inability of the body to maintain normal pH level further contributes to the exacerbation of patient's respiratory distress and also leads to disorientated time and place, as Mr. Birmingham lacks oxygen supply. And at the same time, he is very fatigued and stressed. So my third point is infection with bacteria. Mr. Birmingham's infection with Pastorella multicoda is another critical factor contributing to his clinical deterioration. The infection has caused a systemic inflammatory response, as indicated by increased level of C-reactive proteins and white blood cell count. Likewise, viral and bacterial infection activate several immune cells, including neutrophils, macrophages, and T lymphocytes. The body's reaction to infection is also shown by the high fever of 39.2 degrees Celsius. This systemic inflammatory response increases inflammatory response, leading to bronchoconstriction, as well as increases metabolic demands to fight the infection, further damaging an already compromised respiratory system. The combination of infection and severe asthma exacerbation creates a vicious cycles where worsening respiratory function provokes the systemic inflammatory response and vice versa. So the final point, which is elevated pulmonary artery systolic pressures. The observation in the echocardiogram of an elevated pulmonary artery systolic pressure points to right heart strain, most likely brought by a long-term hypoxemia, as Mr. Birmingham is suffering from asthma for a long time. The hypoxic pulmonary vasoconstriction that results from chronic hypoxemia puts strain in the right ventricle by raising the pressure inside the pulmonary arteries. If left untreated, this can help, and this can develop into right heart failure. The patient's flushed appearance and tachycardia, heart rate of 122, are the response from body to increased cardiac workload and hypoxemia. So these are the pathophysical links. And moving on to the next question, I have a third question. Discuss the pathophysiological link between multiple disease condition that the deteriorating patient has and the clinical presentation. So, Mr. Birmingham's clinical presentation is a result of complex interplay between his late onset asthma, chronic speaking history, and acute infection. So, its condition exacerbates the others, leading to the compound deterioration in his health. The first topic is asthma and respiratory failure. Asthma is characterized by chronic inflammation of the airways, hyperresponsiveness of the airways, bronchoconstriction, and mucus production. In Mr. Birmingham's case, his history of late onset asthma and continuous need for medication like budesonide, formoterol, and prednisolone indicates a severe and poorly controlled condition. During an acute exacerbation, airway inflammation and bronchoconstriction increases, severely limiting airflow and impairing gas exchange in the lungs. This leads to hypoxemia, as seen in his SpO2 of 77%. And hypercapnia evidenced by its PaCO2 of 120. The resulting respiratory acidosis further exacerbates his respiratory distress and contributes to dysfunction of cognitive ability and disorientation. So moving on to next point, I have chronic smoking and asthma. So Mr. Birmingham's history of 50 pack years of continuous smoking is a major factor in how severe his asthma is. Smoking damages and inflames the respiratory system over time, changing its structure and making people more vulnerable to respiratory infection and exacerbations. So smokers have more permanent inflammatory response, which causes more frequent and severe asthma attacks. Chronic smoke exposure also affects the function of cilia in the airways, which decreases the removal of pathogens and mucus and puts the patient at a risk of infection and protracted inflammatory reactions. So the third point, infection, systemic inflammatory response, and asthma. The presence of Pasteurella multicoda in Mr. Birmingham's sputum culture suggests a bacterial infection, which has triggered a systemic inflammatory response. This is evidenced by his elevated white cell count and CRP level, along with high fever. The systemic inflammation increases the metabolic demands and oxygen consumption of the body, further straining on the respiratory system already compromised by severe asthma. This creates vicious cycles when an infection and an aggravation of asthma coexist. The infection makes the asthma worse, and the severe exacerbation of asthma makes infection more likely and more severe. And I have the last point, eczema and asthma. So the relationship between eczema and asthma is remarkably notable in Mr. Birmingham case, as his history of eczema is likely contribute to the severity of his asthma. So both asthma and eczema are caused by inflammation. The National Eczema Association estimates that about 20% of adults with eczema also have asthma. Likewise, 2021 research article indicates that the prevalence of asthma in people with eczema is 14.2 to 52.5%. So this is the pathophysiological link between multiple disease condition and his deteriorating clinical presentation. So moving on to final questions. Question number 4. This is a management plan to address the high priority clinical manifestations. So to address Mr. Formigan's high priority clinical manifestation, a comprehensive management plan must be implemented immediately, focusing on stabilizing his respiratory function, addressing the underlying infection, and monitoring his cardiovascular status. The first one is stabilizing respiratory function. To address Mr. Birmingham's severe hypoxemia and hypercapnia is the most significant management plan for improving his condition. Initiating high flow oxygen therapy or non-invasive ventilation to improve oxygen, which reduces the work of breathing and manages his fatigues. Continuous monitoring of oxygen saturation and arterial blood gas is also essential to assess the effectiveness of the intervention and adjust the oxygen delivery accordingly. So administering high volume of oxygen rapidly would make Mr. Birmingham worse, as it might retain the carbon dioxide. So it is very important that we balance the oxygen saturation from 80 to 92%. So in case of further deterioration, intubation and mechanical ventilation may be necessary. Bronchodilators such as salbutamol can be administered via a nebulizer to relieve bronchoconstriction. Likewise, corticosteroids can also be given to relieve bronchospasm. So my second point is addressing the underlying infection. Given the development of bacterial infection in the sputum culture, initiating targeted antibiotic therapy is crucial. Broad spectrum antibiotics should be started, followed by specific antibiotics once the culture and sensitivity results are available. The choice of antibiotic should cover typical respiratory pathogens. Monitoring in the inflammatory markers such as white cell count and CRP can help determine the response to antibiotic therapy and guide any necessary adjustment. So also at the same time, administering some antibiotic drugs such as paracetamol can bring down his fever. And my third point is monitoring cardiovascular status. The elevated pulmonary artery systolic pressure and sign of right heart strain require careful cardiovascular monitoring. Regular assessment of heart rate, blood pressure, and cardiac output are essential to detect any sign of worsening right heart failure. If the patient shows sign of fluid retention, fluid overload, diuretic like furosemide may be required to reduce pulmonary congestion and elevate right ventricular strain. Most importantly, oxygen therapy should work on him because this is all this all depends on the improvement of oxygen level in his blood. So likewise, echocardiography also should be repeated as needed to monitor changes in cardiac function and pulmonary pressures. So I have supporting care and monitoring. Buster Birmingham's overall condition requires close monitoring in an intensive care unit setting. Continuous monitoring of vital signs, including respiratory rate, heart rate, blood pressure, and oxygen saturation, is very important. Intravenous fluids should be administered cautiously to maintain adequate hydration without exacerbating pulmonary edema. Regular blood tests, including electrolyte panels, renal function test, and ABG should be conducted to monitor the metabolic status and guide further treatment adjustment. So my last management plan is long-term management and prevention. So once the acute crisis is addressed, focus should be shifted to prevent future exacerbation. This includes optimizing his asthma management plan, ensuring adherence to prescribed medication, and educating the patient on recognizing early sign of exacerbation. Smoking cessation support is critical given his significant smoking history, as continuous smoking will worsen his respiratory condition. Regular follow-up with the pulmonologist, as possibly a cardiologist, is recommended to monitor and manage his chronic condition effectively. In summary, Mr. Birmingham's management plan must be comprehensive and versatile, addressing his immediate respiratory distress, underlying infection, and cardiovascular strain, while also planning for long-term stabilization and prevention of future exacerbations. So this comprehensive approach will help improve his immediate condition and reduce the risk of recurrent severe episodes. So these are all my answers to the four questions. Uh, yeah, thank you for the time for listening to my presentation. So I like to